All right. Hi. Hi, everyone, and welcome to today's echo session. I think it's really been a learning journey from the feedback that you've been giving on the WhatsApp for this batch, and Erin can also attest to that. Yeah, so in the interest of time, we'll go ahead and start off our session. We'll have a didactic session, then a case presentation later by part of the faculty. And if you're still looking forward to introduce yourself, you could just type it on the chat box. Meanwhile, if you're not speaking, you could put your video off so that we focus on the presentation. So this afternoon, we are privileged to be joined by Dr. Kathryn Richardson, who is palliative care consultant and has been a faculty member of the ECHO sessions, and this time also being a faculty in this batch 2 of our training. So she's a palliative care consultant who's been working for MSF in a global role that is supporting palliative care and in a variety of humanitarian sessions. So she's a great resource even as we go through our topic this afternoon or this morning. I see we are joined by people from different parts of the world. So she's also an executive committee member of PALCHES, and PALCHES as well as KEHPCA, the organizations that are bringing to you this ECHO palliative care humanitarian sessions. So Dr. Kathryn will be taking us through symptom management, looking at common symptoms that we'll experience as we take care of patients living with palliative care needs. So I'll hand over to her. If you're able to share your slides, please go ahead, Dr. Kathryn. And my name is Dr. Esther Muinga. I work with Kenya Hospices and Palliative Care Association. Welcome all. Go ahead, Dr. Kathryn.
Super. Thanks so much, Dr. Esther. And I'll just share my screen.
Okay.
Okay, can you see my slides?
Yes, your slides are visible.
Great, thank you. So today's session, so last week we learned about pain management, and this week we're going to have a look at some other physical symptoms which are common in advanced disease and in patients requiring palliative care. And we don't have time to go over all symptoms because there are many. We're going to focus on nausea, vomiting, and breathlessness in this session. But just before we start, I'd like you to just think about other symptoms that there may be in patients needing palliative care, so other symptoms that you have seen in your patients that have advanced disease, and you can just write those in the chat. And I'll ask the faculty members to maybe put some in if there's some gaps. We'll give the participants, if you go first, and we can fill in some other symptoms as well. Is there a problem with the audio?
Sorry, just go ahead. For the rest of the participants, kindly mute your mics if you're not speaking. So go ahead, Dr. Richardson. Sorry about that.
No problem. So if you just write in some other symptoms, and we'll have a look at those as we go forward, and we'll ask the faculty members also to add in any gaps, so we can just start thinking through the kind of physical symptoms that we may need to that we may find in our patients, that we need to do an assessment of and manage as we can. And before we jump into nausea and vomiting, just want to give you some general guidance on symptom management in palliative care. So when we think about managing a symptom, the first thing we think about is, so first of all, we do an assessment of that symptom, okay? And then we think about, can we treat the cause of the symptom, okay? And if we can, that's always the best option. And we may need to treat the symptom at the same time, but sometimes we can't treat the cause of the symptom, and in which case we treat the symptom itself. So that's just a basic principle that we apply for all of the symptoms that we find. And we'll talk more about that as we go through. So we'll look first at nausea and vomiting, and nausea and vomiting are common. It's common symptom. They're common symptoms in palliative care, and nausea and vomiting can occur in different types of advanced illness. Okay, and here we have Here we have some common causes of nausea and vomiting. So one of them would be medications, okay, and morphine, as we learned last week, can cause nausea. That's usually temporary, but other medications like antibiotics, chemotherapy agents can also cause nausea and vomiting too. And if you think about that principle of managing pain, we can sometimes, managing symptoms, we can sometimes stop the medications causing nausea and vomiting, and sometimes we can't, okay, because we need it as the management plan, in which case we treat the symptom. So other important causes to think about are metabolic causes, so things like hypercalcemia, which we see in patients, we may see in patients with bone metastasis from a cancer diagnosis, and nausea and vomiting are common in patients with advanced liver disease and also advanced kidney disease from the uremia, high levels of urea in the blood. There are gastrointestinal causes of nausea and vomiting, so constipation or other causes of gastric stasis. Ulcers can cause nausea and vomiting, and bowel obstruction. Okay, and bowel obstruction may be due to a cancer diagnosis. It may have another cause. So then there are central causes of nausea and vomiting, and we'll talk more about those later, and vestibular causes too. And sometimes it might be a combination of more than one, and sometimes we can't identify the cause. But the principle of managing nausea and vomiting is to try, just like pain, try and find out the most likely cause of it, and that guides how we can treat it. So if we want to know the cause of nausea and vomiting, then we need to do a careful assessment, a careful symptom assessment, and we can use the similar questions that we had for the pain assessment last week. So we can ask about how long the symptoms have been present, if the nausea is there all of the time, or is it associated with particular times of the day? Is it related to food? Is there vomiting, or is it just nausea, etc., etc.? More details about the vomiting. So we can find out more about the symptom, so we can best identify the most likely cause. Sometimes we need to do investigations. Some examples might be, if you're lucky enough to have access to a calcium or the kidney function test, they may help you to identify a cause. If you're lucky enough to have access to abdominal X-ray, that can help identify bowel obstruction. And sometimes we're making clinical diagnosis. It depends what you have access to in your area of work. And here is a picture from of a patient in the Dadaab camp in Kenya, being seen by the medical team in his hut. So the management, as we've already mentioned, is wherever possible we can treat the cause of nausea and vomiting. Okay, so if someone comes in with hypercalcemia from malignancy, we can give fluids and see if the calcium comes down. If someone comes in with obstruction, whether it be due to constipation or a mechanical bowel obstruction, we can think about if there's a solution for that. There may be a surgical solution for bowel obstruction for some patients. We look at any medicines that may be contributing to the symptom. We may or may not be able to change them. Okay, we may not be able to, for example, stop a person's antibiotics or morphine or other drugs, so we may need to give antiemetics. And just like when we were managing pain, for patients that have nausea all of the time or most of the time, we need to use regular antiemetics, because if we use them SOS, the person is each time waiting for the symptom to come back, and it will take them time to get rid of the nausea with an antiemetic. So it's much better to give them regularly to take the symptom away. And we can think about the route. Now, in pain management, you'll remember we said always start with the oral route. It's the same for nausea, but obviously if there's vomiting present or there's bowel obstruction, then we're not going to be able to use the oral route, and we need to think about using injection. So we might be using subcutaneous injection or IV injection. Oops. And you know, some things can make nausea worse. So if you have very strong odors with food in the patient's home or in the facility, try to remove those, because they can make the nausea feel worse. And you can do things like a cool damp cloth to the forehead and wrist. That may just help for someone who's feeling very nauseated. And of course, if the cause isn't constipation, just exclude it to make sure that there isn't constipation making the symptom worse. Constipation's a common, another common symptom in palliative care, and that's just going to prompt me to have a quick look at the chat and pause here to see what symptoms you've come up with. So that's super. So we've got lots of thoughts here. So constipation, you've got it there already. Anorexia and cachexia, excellent. Fatigue, delirium, dehydration, malnutrition, wounds, gastritis, shortness of breath, dizziness, insomnia, super. Seizures, decreased appetite. Yeah, so that's really good. So we've got lots of symptoms there. There are other symptoms too, but that's really good. And I think it just gives us a flavour of the kind of problems that you may be faced with when caring for patients requiring palliative care. Okay, back to nausea. So when we teach palliative care, we think about mechanism-based management for nausea and vomiting. So we choose the antiemetic depending on the most likely cause, because that tells us which target we need to try to hit, which receptor we need to try to hit to improve the nausea and vomiting. Okay, and if we use this approach, we're much more likely to be successful with our antiemetics than if we don't. Okay, so this is what we recommend. Having said that, we know that in a lot of the settings you're working, you may not have access to many antiemetics. Okay, you may not have many choices. You may have 2 or 3 antiemetics available, in which case you just, where you can, you select the one that's most appropriate. And we'll talk through the ideal situation as if you had access to all antiemetics, but we know in reality you may not have the antiemetic you want, either because you don't have it in your setting, or because we know sometimes there may be a stock rupture or other reasons. So keep in mind, this is the ideal situation, and then you then work as best as you can to follow that, knowing there may be gaps. So when we think about drug causes for nausea and vomiting, so we already mentioned some medications that can cause nausea and vomiting. So things like opioids, things like antibiotics, chemotherapy, treatments, if you have access to those. We know that the best choice of antiemetic, and I want to not make this too medical because I know we're not all doctors on the call, the best choice of antiemetic is either metoclopramide or haloperidol. Okay, and that's because of the way that where it acts and the neurotransmitters involved in that mechanism. Okay, so drug causes, metoclopramide might be your first choice, and second choice may be haloperidol. So for chemotherapy, for patients on chemotherapy, it depends a little bit on the type of chemotherapy they're receiving, but often we use, often it involves serotonin pathways, and we use, if you have access to it, ondansetron or granisetron. Now, these are not always available in all settings. They can be expensive, but if you're giving chemotherapy or you have chemotherapy in your facility, then you may well have access to these medications. And for vestibular causes of nausea and vomiting, then we use the antihistamines. Okay, we use antihistamines. Mostly cyclizine might not be available. Okay, that's not widely available, but you may have access to promethazine. Okay, so that's one we can use. Just a note about promethazine: we often use antiemetics in the subcut route, and the ones we've mentioned already, metoclopramide, haloperidol, ondansetron, can all be given by subcutaneous injection, but promethazine cannot. Okay, it can cause local irritation of the tissue, so you need to give it by IV injection if you're using promethazine. And when we think about visceral causes, so things like bowel obstruction, okay, there may be dopamine and serotonin neurotransmitters involved in this pathway. So when you have bowel obstruction, often we would use metoclopramide. If you have a complete bowel obstruction, a mechanical bowel obstruction, rather than a sort of functional bowel obstruction or a partial bowel obstruction, you avoid metoclopramide, because if you give a drug that triggers peristalsis and you've got a complete obstruction, it can risk perforation. Okay, so if you use metoclopramide and the patient has some obstruction and they get a lot more pain and colic, then it should be stopped. Or if you suspect complete obstruction, select one of the other medications here. Okay, so we've got ondansetron or haloperidol. And raised intracranial pressure. So this can also cause nausea and vomiting. So this is for patients with, it may be a brain tumor, it may be raised intracranial pressure from TB meningitis or cryptococcus or other cause of raised intracerebral pressure. Then the medication of choice is one of the antihistamines. Okay, so cyclizine if you have it, if not promethazine. And we use dexamethasone as well to reduce some of the cerebral edema, which helps with nausea and vomiting too. So remember to ask patients about whether they have nausea and vomiting. Patients don't always report it. A full assessment of the symptom to make sure, to try to find the most likely cause. And remember to prescribe antiemetics regularly for patients that have frequent or continuous symptoms. Sometimes you may not have access to the antiemetic of choice that we've just gone through for the different causes, in which case use the most sensible either second line option for that cause or the closest one you have. Okay, and sometimes we do need combinations of antiemetics. For some patients, particularly for patients with malignant bowel obstruction that is being managed conservatively, so without a surgical management plan, it can be really, really difficult to get on top of nausea and vomiting. It can be a symptom that's really associated with a lot of suffering for the patient. So if you're struggling and you have patients with really resistant nausea or vomiting, then do reach out if you have telemedicine support or to the faculty here for some support with how to manage it, because it can be difficult to manage. Sometimes for malignant bowel obstruction, we might use an NG tube to palliate the symptom, but that's sort of, a lot of patients don't like NG tubes in, but sometimes relieving the obstruction using an NG tube can reduce the suffering for some patients. So we've already sort of touched on this, and I don't want to go over too much more detail. So we've got here the classes of antiemetics that we've just gone through. So those that work on the dopaminergic receptors, the anticholinergic receptors, the antiserotonergic receptors, and antihistamines as well as others. Okay. So we've gone through already the uses of metoclopramide. So this will be for medication-related nausea, vomiting, or for sort of constipation. Okay, so gastric stasis, and the usual dose most of you are familiar with, 10 milligrams, either 8 hourly. You can use it 6 hourly, and you can double the dose if needed. Above that, you can go up to 20 milligrams TID or QDS if needed. Okay. And as we said, avoiding bowel obstruction because of the perforation risk, and that's a complete bowel obstruction. It's actually quite good if you've got a partial bowel obstruction because it can help with peristalsis. And if you've got patients with moderate severe renal impairment, we usually use at least 50% dose reduction. If you have domperidone, it's in the same family as metoclopramide. This is only an oral medication. It's not widely available. Some of you may have access to it. The dose is here, so it's 10 milligrams every 8 hours, and it has similar mechanism of action. The difference is it doesn't cross the blood-brain barrier like metoclopramide, so it has reduced, you don't get the extrapyramidal side effects that you get with some patients with metoclopramide. Similarly, for patients with renal dysfunction, we reduce the dose. So haloperidol, and I think for healthcare workers that are not familiar with palliative care, often there's not a lot of experience in using haloperidol for nausea and vomiting, okay? And we use haloperidol at much lower doses than you would use as an antipsychotic medication for managing nausea and vomiting. And it's actually a really effective medication. And what we find is when you use it at low doses, it doesn't have the same sedating side effects as you have at higher doses. And we can use sometimes as little as 0.5 milligrams twice daily. Now, you may only have access to the 5 milligram tablet, so it may be difficult to give such a small dose. But you can divide that into 4, and you can use, 1.25 milligrams would be a sort of quarter tablet, and you can use that at bedtime, and you can increase that to 2 or 3 times daily, depending on the symptom. And usually, when you get to about 10 milligrams in 24 hours of haloperidol, you don't really get much additional antiemetic effects. So you can titrate up. So you may go from 1 milligram 2 or 3 times a day to 2 milligrams 2 or 3 times a day. But usually by that dose, if you're going to have a response, you will have it at that point. And it's very effective. And it's one of our favorite antiemetics, I would say, in palliative care, because it's a bit broader spectrum in terms of its so there are other antipsychotics that you can use that are also slightly broader spectrum that are mentioned here on the bottom. You may have access to chlorperazine. You're unlikely to have levomepromazine, but they are quite broad spectrum antiemetics. They do cause some sedation, but again, we use it at much smaller doses than we use than antipsychotic doses. It's much smaller doses. So they're usually at very low doses, quite well tolerated. So for some patients that have chronic nausea and vomiting, we can give them some other support, some sort of non-pharmacological support. To be quite honest, I think the role of this is quite limited in patients with advanced disease, because sometimes their nausea can be quite difficult to treat. But you may have local herbs that are used for managing nausea and vomiting. Classically, ginger is one that I'm aware of that can help. And sometimes you find patients eating ginger biscuits or chewing en route ginger, and they find some relief from that. And there's a couple of other suggestions here, lemon tea or cardamom. So please do share if you have any local remedies that you use in your setting that you have that are known to help with nausea and vomiting. But like I said, I think it's fine to try them, but I think often in advanced diseases you do need antiemetics as well. Okay, so that's all I'm going to say about nausea and vomiting, and I hope it wasn't too medical for the non-doctors in the group. We're now going to have a quick look at breathlessness, which is another very difficult symptom for patients and their families while they watch their loved one with breathlessness, and it's also very common. Okay, and what we mean by breathlessness, it's the sensation of feeling short of breath. Okay, so it's not the respiratory rate, it's not the oxygen saturations, it's not what you think of the person's symptom, although we may need to go off that if the person themselves cannot report breathlessness, but it's usually a self-reported symptom. So it's the experience of feeling breathless. And just like pain is whatever the patient says hurts or whatever the patient says is pain, it's the same for breathlessness. Okay, so if a person reports breathlessness, even if their respiratory rate is normal or their oxygen levels are normal, then they're experiencing breathlessness. Okay, so it's a subjective symptom. And so you can see here around half of patients referred for palliative care experience breathlessness. It's most common in the last weeks of life, and sometimes breathlessness or seeing a patient breathless can be a guide that that person might be approaching end stage of their illness, the last weeks or even days of life. So if you see a person who maybe you're about to discharge home and they seem very breathless, just think twice, you know, are they actually more advanced in their illness than you think? Okay, so it can be a very sort of last days or short weeks of life symptom. And if you're looking after patients with cancer diagnosis, it says here around 2/3 of lung cancer patients present with breathlessness, one of their presenting symptoms. And it's common also in patients that do not have lung disease as well. Okay, so it's a common symptom. So breathlessness may be described in different ways by patients, and you can see here some ways. So air hunger, okay, so this gasping or this need to breathe, need to sort of can't get enough breath in. Okay, so that's how some patients may describe it. Others may describe it of the effort of breathing. Okay, so they're using all of their sort of I'm not finding the words, the accessory muscles for breathing. Okay, so if that's the case, they can feel tired or a big effort associated with breathing. And others may describe it as a sort of tightness in the chest, so they feel sort of constricted and unable to get the air in that they need. So these may be some of the descriptions you've heard of patients, and it may be the different ways of them telling you that is that this is the symptom of breathlessness that they're experiencing. Simon, you've raised your hand. Would you like to ask a question now? Please feel free. I think the hand might have gone down. I'll carry on, but we can have some questions at the end as well. So if you do have a question, you'll have time for that. So we've got here some common causes of breathlessness in palliative care. Okay, so cancer diagnosis is one of the global leading causes in adults of the need for palliative care. And if you have tumours in the lung tissue or the airways, it can cause breathlessness. So that will be a common presentation of breathlessness in all settings. Infection, sort of pneumonia. We know patients needing palliative care are more susceptible to infections and pneumonia. So this may also be a cause. It's also a common cause. If you have patients with end-stage lung disease, whether COPD or restrictive or other lung disease, or congestive cardiac failure, so end-stage heart failure, or patients have had pulmonary embolism, will all can present a very common presentations of breathlessness. Respiratory muscle weakness may be another cause. And then there's some others that are not related to the lungs, so things like ascites. And when you've got, many of you will see patients with very tense ascites, and it actually pushes up, pushes the diaphragm up and reduces lung capacity. Okay, so it can be a cause of breathlessness. Anemia, another cause of breathlessness, and anxiety. Okay, and we know that in patients needing palliative care, levels of anxiety are often high. Okay, so anxiety can cause breathlessness, so remember to think of that too. So just like nausea and vomiting, wherever possible, we treat the underlying cause. Okay, so if someone has a treatable cause of breathlessness, such as pneumonia, and they're not at last hours, days of life, then we would give antibiotics, and hopefully that would improve the breathlessness. And then we have some other ways of managing symptoms too, when we can't treat that underlying cause. Okay, we'll go through those now. But in general, there's pharmacological ways to manage breathlessness. You may use oxygen, although that may be helpful in facility, but often there's no access to oxygen outside of the facility. For patients with tumours, they may have access to oncology treatment. And remember this multidisciplinary approach or holistic approach. We've got the word total dyspnea here. So this is meaning looking at more than just the physical. Okay, so we think about any anxiety that may be contributing, or other issues, spiritual or social issues that may be leading the person to have worsening of that symptom. Okay, so what helps? What helps with breathlessness? So before we move on to the medications, we can help patients with positioning. Okay, and often if patients are sat down and using their arms to lean forward onto their legs, almost like in a tripod stand, often that's a helpful position to be in for patients that feel breathless. And you'll find that patients often sit up rather than lie down when they've got quite severe breathlessness. There's very good evidence for using fans, either a handheld fan or a fan in the room, to help with breathlessness. And that experience of air coming onto the face does help with breathlessness, and there's good evidence for that. Where possible, having a draft or open window to let some airflow is helpful, and if that's possible for infection control reasons. And we can help people with some breathing exercise. So we can use what we call pursed lip breathing when we try to lengthen the expiration. Okay, so we lengthen the expiration, and this helps with the parasympathetic nervous system to trigger the parasympathetic nervous system, and it can help a person feel more relaxed. And we can also have more effective breathing. Okay, if we use diaphragmatic breathing, we can give techniques to help with more effective breathing. And we can share some resources on those as well, because we won't have time to go through them now, but I can give you, we can share some resources after the session on those techniques. Relaxation techniques too can be very helpful for breathing, things like the body scan, which again, we can share this after the session, and pacing or priority setting. So if activities of daily living are causing the symptom of breathlessness, so on activity, we can support the person to think about how they can arrange their environment or change their activity levels so that their breathlessness is better managed. So the best medication we have for symptomatic management of breathlessness is morphine, and there's very good evidence supporting its use. We start with lower doses than we do for pain. So we use usually half the dose, so 0.5 milligrams per kilogram per day. And if a person is having breathlessness all the time, we would give it regularly. If possible, orally. We always use oral route when possible, but it's just as effective if you need to give it by subcut or IV route, because the patient is unable to take oral medication. Okay, so you might want to give a trial dose as an as needed or SOS medication first, and if it's effective for the person, then you can give them a regular regime. Okay. So there's some suggested starting doses here. So for an adult of normal weight, you might want to start with 2.5 to 5 milligrams every 4 hours, as well as additional doses too. Okay, and 2.5 because that's a quarter of a 10 milligram tablet. Okay, so it's a convenient dose to start with, and you can increase it as needed for symptom burden. Okay, so make sure when you've prescribed it, you always go back and ask the person if it's helped them. You can also rate the breathing, the breathlessness on a scale like we use for pain, so the 0 to 10 numerical scale. You can ask the person to rate how severe their breathlessness is before the morphine, and then an hour after morphine, you can recheck it just to see how they're scoring their pain afterwards. their breathlessness, sorry, afterwards. So some other useful medications, so there may be a role for steroids, okay, and for breathlessness we might use 4 to 8 milligrams once daily. We give it in the morning because it can, if given later in the day, it can lead to insomnia. So prednisolone, or we tend to use dexamethasone in palliative care because you get less edema, peripheral edema with dexamethasone. And we've got here some conditions where you might think about adding steroids in. Okay, so superior vena cava obstruction or bronchial obstruction. So you're trying to take down some of the inflammation and improve the flow of air through the obstruction. Radiation pneumonitis. So if you're lucky enough to have access to radiation therapy for patients with tumours, that might be a reason to use steroids, so post-radiotherapy. And for some patients with lymphangitic carcinomatosis, steroids can be effective too. This is when you have widespread lymphatic involvement, malignant cells in the lymph system in the lungs, and it can cause breathlessness, and steroids help. Obviously, there's a role for steroids in patients with COPD as well. And often with breathlessness, there is an anxiety component too, okay? And that's obviously understandable. It can be a very stressful symptom to have breathlessness. You will often hear patients talk about they don't know if they're going to survive that attack of breathlessness. So some people feel that this might be it, this might be them dying, they can't get enough air, etc. So it's often associated with anxiety. And so treating the anxiety either with the relaxation techniques, and for some patients you may need to use benzodiazepines, low dose, alongside morphine to help with the anxiety component too, because the anxiety will trigger short, sort of very shallow breathing. So you're trying to relax the person so they can take more effective breaths. Okay, and that's the end of the presentation. Yeah, any questions or any comments, then please do. We have some time for that now. Thank you.
Thank you, Dr. Kathryn. Team, any question or concern that you have for us to address before we move to the next bit of the talk today? Or you could put your hand up. We will give you the chance to speak. All right. That's fine. Thanks, Kathryn. I think that was really insightful. The local contexts, I've also seen ginger working for some patients. However, it has to be, what do we call it? Like you have to take care of the patient on a patient case-by-case basis, because some people react to ginger. So it might be one man's benefit and the other one is not beneficial to them. So thank you for that talk, and you're welcome to stay on. All right, so there's one question before you head out. What is the management of delirium, and is there, sorry. All right, so the question is, what is the management of delirium, and is there any side effect of, I don't know if you mean benzodiazepine, Lamech, you could confirm, but he's asking about management of delirium in patients.
Thank you, Dr. Esther. Yeah, so we didn't cover delirium. And the management of delirium, it's a whole other talk, to be quite honest. But similarly to, I'll just say something very brief about it. Similarly to the other symptoms, where you can correct the underlying cause of delirium, whether it be due to a urine infection, or whether it due to be medications or other infections, then treat the underlying cause wherever you can. There's non-pharmacological management of delirium, so it's having familiar faces around, trying to orientate the person, if possible, being in an environment that's familiar. And then there's medical management too, okay? So it depends, again, what medications you have access to. And we usually give medications to prevent the person causing harm to themselves or to others. Haloperidol is often used to manage delirium. If you have delirium in the last hours or days of life, then we often use benzodiazepines, what we call terminal agitation. So when someone's very agitated at end of life, we use benzodiazepines. I'm very sorry that it's a very sort of brief answer. There's an awful lot more to say, but I don't know if that helps. Benzodiazepine, if you mean benzodiazepines, I don't know benzodiazepine, it may be a drug I don't know, but the class, the benzodiazepines in terms of their side effects. So the one thing I want to just share with you mostly is that you get a tolerance to them. Okay, so they can cause drowsiness and sedation, and you do get tolerance with prolonged use. So we use them either for short periods of time for a particular symptom, or for patients in last days and weeks of life. You don't need to worry about tolerance and long-term use. Okay, so they're the things I want to say mostly about benzodiazepines. Thank you, Dr. Esther. I'll pass back to you.
Thank you. I think we'll take one more, then move on the next bit. And then if the rest of the faculty, you could keep responding to the chat as the questions come by. So there's a query about using morphine for dyspnea, and the patient is already on morphine for pain. So the question is, how do you manage that titration?
Yeah, thank you for that. I know Erin's popped a response in the chat as well. So if you have a patient who's on morphine for pain and their pain's controlled, this might not be the situation you mean, but I'll give you an example. The pain's controlled, but they're very breathless. Then this is a reason to increase their morphine. Okay, so you may, just like pain management, you would increase it by say 25% in 24 hours. So each dose by 25%. And just see if that's helping, okay? See if that's effective, see if they tolerate the increase. And then you can just continue to increase in that way until the person has good or better relief of their breathlessness. So I don't know if that helps. We can share some resources. Erin, I think we've got some resources on titrating for breathlessness, so we can share some resources with you after the session.
All right.
Yeah, Dr. Kathryn, I think I just wanted to comment on that, and maybe is this also a similar? You will become more confident in prescribing morphine for breathlessness as you do it. As you see patients responding to it, you will have more confidence. Of course, it's not the standard way we use it, and it's not what we talked about last week, but I think we're a community now here. So if you have a patient that you're hoping to use some, limited morphine that you have because they are severely breathless and you hope that it will improve their quality of life, message us and just say, I'm trying this out for the next 2 days. I think sometimes when we do things that are a bit different, or we may be the only 1 or 2 clinicians in the clinic that are, aware of these different ways to treat symptoms to improve quality of life, message us so that you don't feel that you are doing it alone. And then as you monitor them, report back. Is it working? Is it not? Are the doses working? Are they not? Is the family, responsive to it? Yeah.
All right. Thanks, Erin, and thanks, Dr. Kathryn. We'll move to our next bit of the presentation. Ali, if you're on. So we'll have Ali Khamisi, who is a clinical officer. He had introduced himself a bit earlier. Currently working in a private facility at the Dadaab a Hagdera refugee camp in Kenya, and he's been really pivotal in responding to the need of refugees, and now here in terms of improving access to palliative care services. So he'll be taking us through a case presentation that's focusing on what we've just learned, symptom management. Then after this, we'll be able to have another interactive session. So Ali, karibu. That
Thank
means
you.
welcome.
Thank you so much. My name is Ali Abdullah Khamis from Dadaab, Hagdera Refugee Camp, and I'm also one of the faculty members of Palliative Care in East Africa ECHO program. Today we have a case presentation. The case now, 57 years old man with a chronic obstructive pulmonary disease, COPD, hypertension, and diabetes. This patient lives in northern Uganda with his wife, 2 sons aged 12 years, 14 years. Former day labor has not been able to work with several months due to worsening COPD. You visited him at home. Main symptoms. The main symptoms, what are some questions you have about his symptoms? Case continued. He reports dyspnea, fatigue, anxiety. Dyspnea rated 4/10 at a total rest of 8/10 with activity.
Hey, Ali, maybe we can
Yeah.
just ask the group, just like we did earlier, if they can put in the chat some of the symptoms.
Yeah.
So why don't you just wait a minute?
If I go back there, 15 years old man with a chronic obstructive pulmonary disease,
Yeah,
COPD.
perfect.
He
Yeah,
has hypertension, diabetics. He lives in northern Uganda with his wife, 2 sons, ages 12 years, 14 years. Former day labor has not been able to work for several months due to worsening COPD. You visited him at home. What the main symptoms? Have you noticed it? What are some questions you have about these symptoms? Anybody who can give me the main symptoms?
yeah. If you're interested to unmute, you can also unmute and share with us, or you can put in the chat.
Okay.
One question I would have, Ali, is if he's taking any medication to treat his diseases.
There's a comment from Anita. She says breathlessness. Then Cillian says she would ask the patient, how are you feeling today? And focusing on dyspnea and fatigue. Yeah. Then the other question was, what medications are you currently taking?
Okay, I switch it to the next slide.
Yeah, is the symptom like dyspnea worsening or improving? All right, you could continue.
Okay, thank you. And case continued. He reports dyspnea, fatigue, anxiety. Dyspnea rated 4/10. The total rest 8/10 with activity. Fatigue 4/10. Anxiety 2/10 accepted. Sometimes at night increases to 6/10. Dyspnea improves with the bronchodilators, airflow, open windows, fan, oxygen. What may be your next steps?
So again, you can put in the chat if you have any thoughts about what we could do for the patient. So it looks like we have been assessing the patient based on a 0 out of 10 scale, which is helpful for self-reporting symptoms. What would you suggest to do next?
I hope the next step, the case is still continued. And we come to the management of dyspnea. Disease management, COPD. How might this be different with dyspnea from malignancy, from heart failure, oxygen when saturation is low, airflow, symptoms-directed therapies, OPDs as needed in advance of activity, scheduled. How might you dose the OPD? What might you explain to the patients about the OPD and side effects? So you'll ask those questions. What may you explain to the patients about the OPD and side effects? The case is still continued. Next, Erin. One successful strategy may be oxygen 2 to 6 liters per minute per nasal cannula if possible. Continuing bronchodilators. Encourage fan use. Morphine 2.5 mg per oral, QID for hourly, BRN. New clinical research. You don't need to do this now. Just be aware of more research about OPDs for dyspnea. Next.
That was the last slide. So there's a few comments in the chat, Ali, to give oxygen, which is great. Repositioning the patient so that they can breathe effectively, using morphine, and closely monitoring the patient. These are all really good things. I was just thinking about the settings that we find ourselves in and where we care for them. Can you give oxygen in your refugee camp, Ali, at home?
Yeah, not at home.
Not at
But
home.
we normally give at the hostel, not at home, both in Braves hostel and the IRC hostel.
Okay.
Yeah.
So maybe people on the call today can just be aware, identify where the best places are for their patients to receive oxygen.
Once they are at home and the patient needs oxygen, we normally advise them urgent referral to the hostel so that you get stabilization on oxygen, their oxygen therapy.
Right. But this patient could be, once we got things stabilized with the use of morphine and the bronchodilators and fan, that sort of treatment possibly could continue after discharge.
Thank you. Next, Erin.
Yeah, I think that's it, if there's any questions.
Yeah, we have questions. And our questions here is, what are the main symptoms this patient is experiencing? How do we assess the dyspnea? What are the next steps to treat the symptoms? Explain how OPDs may be used for symptoms-directed treatments. Thank you all.
Yeah, thank you so much, Ali. I think this is a really important case, and I will pass it back to Esther. But Dr. Zippy, I see that you're also on the call. There was one comment. Dr. Kathryn has gone off the course for today, but Dr. Zippy, there was a comment about tramadol when you can't access morphine. Do you have any comments related to that in using tramadol for breathlessness?
Yeah, in our setup, we normally use tramadol.
You also use tramadol, okay.
Yeah, and also morphine. been first used as the first line in terminal first year in this camp. So we have small kits for morphine. So we normally use fast terminal. For critical patients, we normally use for morphine.
Great. Esther, I can pass it back to you.
All right, thanks. Thanks, Ali, for the case, and Erin too. There was I think some feedback also coming in about positioning the patient to help with breathlessness, and then if you're giving morphine to monitor the vital signs of the patient. I don't know if there's any. Oh yeah, then there's the comment about that the patient, it's usually better if the patient is in a comfortable place where they can be loved and supported. So it also helps with like improvement of symptoms generally. Yeah, so Erin, do we do the questions?
Yeah, I think today we can continue. We have maybe 15 or 20 more minutes. We can end a little bit early today. But if there are any particular questions that the group has, we have several of our faculty members still on the call. Dr. Esther, Ali is here, Esther, palliative care nurse. I think Dr. Zippy is on the call, but I'm not sure. So there's quite a few of us still that are here. So if anyone has any particular question about symptom management, there were several symptoms that you shared earlier that we hadn't covered, but we now could go into an open discussion time. And maybe Esther, you can still facilitate that. Would that be okay?
Yes. So there's a comment actually from Esther. Esther says, how anxiety can increase breathlessness? I guess he's asking, how does anxiety and breathlessness go together? Then I don't know if Deborah, you wanted to speak. Okay, she's muted now. All right, so the question about how anxiety and breathlessness go together. Remember when we are talking, oh, the screen is off. I don't think we were sharing any slides. I'm able. Yeah, so anxiety actually makes the patient's breathlessness worse, because remember, anxiety, when we are talking of dyspnea, we are talking about a feeling, and it's subjective. So it's not the health worker reporting, but it's the patient reporting and saying, I'm not able to breathe properly. So if you think anxiety and how it affects the person or the individual, there are those symptoms that are also related to breathlessness. So think about if a patient is uneasy, then they're also feeling this, they have this feeling of they're suffocating or something. Once you treat the anxiety, it actually relieves their feeling of breathlessness. And that's why in the talk we had, like, you can use some of the anxiolytics to help with the breathlessness. Yeah. And then you also say that sometimes the anxiety of the patient can also increase the anxiety of the patient, of the family, increases the anxiety of the family. That is true because, and that's why we say when you're talking about patient care, it's not just the patient as an individual, but patient and the family. So it's usually fair to address both and meeting their needs as they come up, so that if the patients, if the family feels supported, they are able to support the patient even better. Erin, I don't know if you have anything to add on anxiety and breathlessness.
Yeah, I think as I think about the patients that we care for, I'm sure in places like Kenya and East Africa, where we're focusing this course, there probably is a lack of awareness about things such as anxiety. So as we're trying to treat a patient with a very clear symptom of breathlessness, where you can see that patients are extremely uncomfortable, we also may need to, as healthcare workers, just continue to sensitize families about the fact that there might be something else that's also causing them anxiety, and are there ways that we can help them and support them. A lot of people suffer from financial stress when they have a long-term illness. So if you have a patient that is extremely breathless, they are now in the inpatient ward, it's possible to access some sort of counseling or social worker to help the family identify some, barriers or problems they can try to solve to reduce the amount of anxiety. It may be a holistic approach to that. Yeah, and just identifying are there particular people that bring anxiety onto the patient, maybe a specific visitor, or maybe not seeing particular people also brings a lot of anxiety. So I think looking at both angles, and I think it can be a little bit difficult in some of our contexts where it's not, it's also mental health is kind of a taboo subject still. So yeah, it is really important, as Dr. Kathryn was saying, that we try and treat the symptoms. So if you have a patient who is very breathless and you also identify that they seem to be very anxious about the situation, to try and identify that too.
Erin, it's Esther. One activity that I did in one of the courses I took to try to understand what a person who's feeling breathless might be experiencing is trying to breathe through a straw for a minute. And you experience that feeling of just being so anxious because you can't get what you need. But that little exercise has really helped me to understand how people might be feeling when they're expressing that they feel breathless.
Yeah, for sure. And I think also in a lot of the contexts where we are working in humanitarian settings, the environments are not always so conducive, right? It also can be very dusty, can be also feeling claustrophobic if you're in a ward where there's many, many people, or it's visiting hours. So your breathlessness and your anxiety also goes up. These are all definitely things to take into consideration for our patients. If there's ways for us to minimize, especially for a patient suffering from breathlessness, we can try and do what we can. Or maybe they can be, switched to the side of the room or the ward where there's a window. I just added in a link you guys can check out for a website to help cope with breathlessness. This is from the UK, so it's not particular to our setting where we have limited resources, but you can take a look at that.
All right, thanks for the link. And Esther, thanks for the idea, the straw. I've not heard of it, but I think it's worth trying. And straws are really we can find wherever we are. Someone had said they'd used opioids in children for breathlessness, and it did work. So as Erin says, the more we practice, the better we get at it, the better we get at our patient care. I don't know if there's any other concern that we have not tackled. Okay, Dr. Aimable says, apart from family approach, in a holistic manner, benzodiazepines can also help with anxiety. Thanks. And the health workers also have to become, there's something we also call verbocaine, if you've heard of it, really meaning that how you speak or how you behave around a patient does help in terms of soothing them or making them more comfortable. So they can also read your moods and in worsening their symptoms or improving that. Go ahead, Erin, you had a comment.
Sorry, I think just on an administrative note, the attendance sheet, I just haven't, it's the proper link, but I haven't updated the date. So let me just do that quickly now. But I think one of the messages from Lamek, one of our nutritionists or dietitian, said, what are the causes of anxiety? And I think that might be an interesting discussion to talk about with this group. And you guys might be in a better place to answer that for us because these are your patients. But what, I mean, I can definitely think of several, but what are other causes that you guys identify that brings anxiety on a patient? I mean, having a life-limiting illness would be one. If they're a refugee, you know, being displaced.
And Ali, you can also add to that because you are also working within the humanitarian setting.
Yes.
The question is what are the causes of anxiety among patients?
Ali, in your context, do people that are Somali refugees talk about their anxiety?
Yeah, mostly they present anxiety, one of the symptoms, and mostly it's due to some stress, and sometimes they had post-trauma and stress. Maybe their children, they left their children in Somalia, they were killed by a militiaman. They left their parents. Somebody comes displaced, this way he was living. They came as refugees. They don't have shelters. They become near Rabalia. When you meet with them, most of them, they are complaining about anxiety.
Mm-hmm.
And some other people, they have underlying diseases. Their diseases were not being informed. They go to the in Somalia hospitals. When they came here, is when they were informed. You have this problem. They feel anxiety, most of them. So that's the main problem. Mostly they have the symptoms in the refugee camps.
And do you find that there are ways that you can support patients in these really difficult situations when probably a majority of your patients are dealing with those same kind of contexts? Do you
really in our setup we have a lot of community workers,
yeah,
and mental health workers in refugee setup, and they were trained in counseling, and they were trained in how to handle such patients. Even us, sometimes we visit at the home level, and we give more support, and we ask them what their need is. If they need hostel support, we normally give them the support and treat and ask them some their history and give them the required treatment. Some of them, if they need palliative care services, and we know that they are special needs, we normally support them, and we normally visit them weekly basis. And also our community workers, they normally refer such cases when they saw, and they normally give us a call.
mm-hmm.
Yeah.
Do you guys have the ability to have support groups at all in your setting? Or is there still stigma?
In our setting, we have something called help mothers. I mean, mothers to mother support and man to man support in our setup. We have also a special staffs who normally work with the health committees. In each block, in each village, they have health committees, they have block leaders, and they have community leaders. So in case of anything happen, immediately the community leader or health team, they will call you. They will pass through the community health workers. Immediately we get the information. So we send ambulance and we send visit weekly basis, so that we bring patients who are in need for hospital support. And also we clarify whether this patient needs palliative care or whether this patient needs general medications or general support. If some other patients even need rehabilitations, You have an LWF, lower and federations, who normally deal with rehabilitations and disability. If these patients also require support for children, you have TDH who supports children. If these patients need is also in gender-based violence, we have a woman empowerment office. We normally send them. Every patient has a referral category. Yeah.
Do you guys have access to a psychiatrist or psychologist, or is it mainly you that are treating?
We normally have in the hospital, you have psychiatric department.
Okay.
Who normally deals with mostly with mental and counseling also.
Yeah.
Even me, I'm also a psychologist.
Nice.
Basic psychology, yeah.
Hmm.
We normally give them counseling and support them.
Yeah.
Yeah.
There was a question about how to assess anxiety. I can look up some tools. I mean, I think if you are in a bigger facility and you have access to people who have done further education or have specialized in psychiatry or psychology, it would be best if you were quite concerned about the patient, that they may have severe anxiety, to get the team involved. But I do think that we can support patients to identify, even just using the simple scale that we've used before on a 0 to 10, how much anxiety are they feeling right now? So a self-reporting tool also could be effective, but if a patient is in severe distress, I think it is important that we call for referrals.
Yes, you can still share with us in the email and those tools, which will be helpful for us to guide us.
I know at KNH, where one of our faculty members, Dr. Nafula, works, they use something called the distress thermometer. So it helps people identify, again, on that scale 0 to 10, how distressed they're feeling, and then also helps identify what could be some of the causes. Some of them are social, some of them are health related, some of them are, emotional. I know Esther just shared also possibly getting some spiritual help. People can also have anxiety because of spiritual issues. So I can share that tool.
Thank you.
All right. Thank you, Erin. Thanks, Ali. The reason for doing this course is so that we are also empowered to support patients at our capacity, because we believe there's always something that you can do to help the quality or improve the quality of life of the patient and the family. So the questions you're asking are actually great, as well as the comments. We've seen them in the chat. So going forward, once we get more reading materials available to you, we'll be able to share also on the platform, as Erin has highlighted. And if there are more questions, feel free to get in touch with the faculty and with the rest of the members of this training session. Erin, there was an interesting, is it comment or job description? There's someone who's joined us as an end of life midwife. So I'd be interested to find out what that entails. I've not heard of it before. So is it like a profession at the end of life only, during delivery?
Yeah, I think
that would be really interesting. Yeah.
I think she's actually from Canada. She used to live in Kenya previously, but yeah, I think it's an unregulated profession currently at the moment, but it is the idea that just as we have midwives that help babies enter into life, we also could promote the action of a midwife, so someone who's trained in death and dying, to walk with people as they die. So I don't think it's a regulated thing. I believe it's usually paid for privately by a family, but I think probably agrees with many of the same ethos as what palliative care is. I'm sure they would be considered part of the palliative care team. So.
Yeah.
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 I know, of course, midwives in most countries are regulated, but I believe this particular type of midwife, you know, in particular for end of life, the end of life journey, not that I'm aware of that it's regulated, but yeah. But yeah, it's always interesting to hear what, you know, what is up and coming or what are different options for people if they're interested.
All right. We'll share also the distress thermometer on the chat so that you see it's just a visual to help the healthcare worker ask patients questions so that you don't miss out anything. So it looks at basic symptoms that the patient might be experiencing, and then they're rated. So it's called a thermometer because when it's red or hot, it means the symptoms are really severe. And then mild will be at the end of the scale. It's just a simple tool. It's a validated simple tool that we use to monitor or to follow up patients in terms of their symptom burden. Don't think I see.
I'm just sharing it right now.
She's responded. Bettina said it's not regulated. I'd love to chat on it offline. All right. Okay, Esther, thanks. There are non-medical people who are trained to work with people during end of life. I think that is really helpful in terms of taking care of those anxieties that come up with the end of life issues. And someone had mentioned one of the issues that the patients might be going through when we are talking about, when we had the case presentation, was how will they leave their children? How will they be buried? Will they experience pain? Will they die in pain or in dignity? So those questions come up. Yes, and that's the thermometer. So if you can see the top part where it's 10, that's where I would call like the red bit. So we say that the patient has extreme distress. So it's really like scoring their symptoms on a score of 1 to 10, where 10 is the most distressful bit, then 1 is mild symptoms. So it just helps you with follow-up and referral of the patients. Thank you, Erin, for sharing. I hope the screen is clear for all of us. Mohammed, that's better for you. All right.
I can also, I can share it as an image if you are in the, or if you're able to be introducing new ways of assessing and introducing new things in your clinical setting, then you'd be welcome to use that as a tool. So I can make sure I share that on the next email so you can print it out. We'll probably end there. Dr. Esther, thank you for facilitating. You've been great, keeping the group on task, and we're even ending a little bit early today, which is great. Next week, we will be meeting the same time, same place on Zoom, and we have Professor Julia Downing, who is the Chief Executive of the International Children's Palliative Care Network, speaking on how to provide palliative care for children in humanitarian settings. She's a nurse and has worked in Uganda for many years, and she's currently leading the international group that focuses on palliative care for children. So she's been a faculty with us for, now this is her second time, which is great, and she's always supportive of different people working in settings like this. So I hope you can join. It is an open session. So if any of your colleagues or pediatricians or pediatric nurses are working in your area and you do find that you are sometimes dealing with children that are not able to be cured or are either actively dying or have long-term issues, then we would love for them to attend. So it's an open session. You can share the link with them. And yeah, hopefully we'll see you then. Please sign the attendance. And if you have any further issues, you can email me during the week. Thanks, everyone.
Thank you, Erin.
Thanks.